Am I audible now? Now am I audible? Yes, guys. I think I must be audible by this time. Okay, guys. Arun, Charu, am I audible now? Yes. Okay, guys. Fine. So what I was telling is, yes, what I was telling is we will be seeing the gross anatomy of the abdomen first, and by completing the gross anatomy, we'll then go to the embryology and histology of the abdomen, because only when you understand the proper orientation, then only you can understand the embryology easy. Okay, it will be easy for you to understand that. So without wasting much of the time, we'll start with the first topic of the abdomen, that is inguinal ligament. Okay, see, before going into the inguinal ligament, okay, you should know, or you should have a basic orientation of certain things in the abdomen. Okay, so basically the abdomen, anterior abdominal wall. Okay, if you see the anterior abdominal wall, okay, it has got the following muscles. Okay, it has got external oblique abdominis muscle, it has got external oblique abdominis muscle, it has got internal oblique abdominis muscle, it is called as an internal oblique abdominis muscle. Next, there is a muscle called as transverse abdominis muscle, transverse abdominis muscle, and there is another muscle called as rectus femoris muscle. There is a rectus abdominis muscle, there is a muscle called as rectus abdominis muscle. Okay, so if you see, the rectus abdominis muscle is in the is occupying the center portion of your body, and all the other three muscles, the obliques, are from the sides. Okay, they run from the posterior to the lateral aspect of your body. Okay, if you see the abdominal muscles, okay, so you should know at least the origin and insertion of the external oblique abdominis muscle, so that you can understand the inguinal ligament clearly. So what I'm going to do is, I'm going to draw a simple diagram here. So this diagram represents the sternum, okay, and this represents the xiphisternum. Okay, xiphisternum, and I hope you know the ribs which are attached to the sternum. Okay, so you got the ribs which are attached to the sternum. So this is the sixth rib, this is the fifth rib, okay, and this is the fourth, and this is the third rib. Okay, so this is the third, fourth, and fifth and sixth rib, and next comes the seventh rib, next comes the eighth rib, next comes the ninth and the 10th rib, 11th and the 12th rib. They does not articulate with the above ribs, so they are called as floating ribs. They are called as floating ribs, and they form this margin called as costal margin. So they form a margin called as what? Costal margin. So this is called as the costal margin. This is called as costal margin. When you go below, okay, so you can see the iliac crest here. You can see the iliac crest. Okay, you can see the iliac crest, and this iliac crest, as you all know, it anteriorly forms the pubic symphysis. Okay, and the obturator foramen you can see very well here. Okay, I hope you know what is this crest called as. What is this crest, guys? This crest is called as the iliac crest. Okay, this is called as the iliac crest. Okay, this is called as an iliac crest. This is called as an iliac crest. If I draw a line through the highest point of the iliac crest, if I draw a line, I'll draw it in a different color. If I draw a line through the highest point of the iliac crest, then that line is called as supracristal line. Then that line is called as what? Supracristal line. Okay, this line will go through the L4 vertebra. This line will go through the L4 vertebra. So the line which passes to the highest point of the iliac crest is called as the supracristal line. Okay, in the morning when we were talking about the iliac crest, I told you that there is an elevation here. Okay, 5 centimeter behind the anterior superior iliac spine, there is an elevation here, that is called as an iliac tubercle. If I draw a line through the iliac tubercle, then this line is called as a transtubercular line. This line is called as an transtubercular line. This transtubercular line runs through L5 vertebra. It runs through L5 vertebra. This is called as a transtubercular line. Okay, if I draw a line through the L1 vertebra, okay, if you see here, you have the L1 you have the L1 vertebra here. Okay, you have the L1 vertebra, and if I draw a line through the L1 vertebra, okay, if I draw a line through the L1 vertebra, then that line is called as the transpyloric plane. So this line is called as a transpyloric plane. This is called as a transpyloric plane, guys. This is called as transpyloric plane. So you should know about these planes in the abdomen. So transpyloric plane, supracrystal plane, and transtubercular plane. Okay, so you should know about these planes. Okay, and when you take the first muscle here, okay, so this is just to give an introduction to the ribs and the sternum and the pelvis orientation here. So when you come to the first muscle, that is external oblique abdominis muscle. Okay, external oblique abdominis muscle, it is a very, very broad muscle. It is a very huge muscle. Always remember, when the muscle is very broad and huge, okay, it inserts by means of an aponeurosis. They don't form a tendon. Usually tendon is a cord-like structure. Okay, tendon is a cord-like structure, but the abdominal wall muscles, they insert by means of aponeurosis. They insert by means of aponeurosis. They insert by means of aponeurosis. So if you take the external oblique abdominis muscle, external oblique abdominis muscle takes origin from above. Okay, it takes origin from above. It takes origin from the lower 8 ribs. Okay, it takes origin from the lower 8 ribs. So if you see here, from the fourth, okay, from the fourth to the 12th rib. Okay, it takes origin from the 4th to the 12th rib. So it is a very, very wide muscle. It takes origin from above, and you just see the direction of the fibers. Okay, how it is running. This direction of the fibers is important in identifying this muscle. So when this muscle starts from the 4th rib to the 12th rib, okay, so lower 8 ribs it arises, it runs in an downward and medial direction. It runs in an downward and medial direction. How? See, if you put your hand into your pocket, if you put your hand into your pocket, the direction in which your hand goes into your pocket, so that is the direction in which this fibers go. So this fibers, so the external oblique abdominis muscle, okay, the external oblique abdominis muscle, okay, it arises by it takes its origin from the lower 8 ribs. It takes its origin from the lower 8 ribs. Okay, it takes its origin from the lower 8 ribs. When it takes origin from the lower 8 ribs, okay, it runs downwards and medially, and it gets inserted. Okay, it gets inserted into the xiphoid process. It gets inserted into the xiphoid process. It gets inserted into the linea alba. It gets inserted into the linea alba. Okay, so these are all the insertion of the this muscle. So it gets inserted into the linea alba. It also gets inserted into the okay, outer lip of the iliac crest. It is also getting inserted into the outer lip of the iliac crest. Okay, after getting inserted into the outer lip of the iliac crest, okay, this muscle forms a ligament here, and this ligament is called as the inguinal ligament. So what is inguinal ligament? Inguinal ligament is the downward folding of it is unfolding of the lower border of the external oblique abdominis muscle. So what is inguinal ligament? Inguinal ligament is basically a folding of the lower part of the external oblique muscle. Okay, so if you see this muscle, so it is forming the inguinal ligament here, and is getting inserted into the pubic crest here, and it is getting inserted into the pubic crest here. Now when it comes to the pubic crest, this muscle gives a big defect here. Okay, this defect, what you see here, is called as the superficial inguinal ring. So this is called as what? This is called as superficial inguinal ring. Okay, so this is called as superficial. This is called a superficial inguinal ring. This is called as a superficial inguinal ring. Okay, so if you see this muscle, where this muscle gets inserted, this muscle gets inserted into, okay, this muscle gets inserted into the xiphoid process. This muscle gets inserted into the xiphoid process. This muscle gets inserted into the linea alba. They form the linea alba, which encloses the rectus abdominis muscle. They form the linea alba. Okay, it gets inserted into the outer lip of anterior 2/3 of iliac crest. It gets inserted into the outer lip of anterior 2/3 of the iliac crest. Okay, it also forms the inguinal ligament. And finally it gets inserted into the pubic crest. So this is the attachment of the external oblique abdominis muscle. This is the attachment of the external oblique abdominis muscle. What is the take home message here? So in the external oblique abdominis muscle, there is a small defect which is seen. close to the medial side, close to the midline, and this defect is called as what? This is called as superficial inguinal ring. This is called as superficial inguinal ring. Okay, this is called a superficial inguinal ring. And if you take the inguinal ligament, okay, this inguinal ligament, if you see here, it is attached laterally to this point. This is called as the anterior superior iliac spine, and here it is attached to the pubic tubercle. Here it is attached to the pubic tubercle. This is the attachment of the inguinal ligament. So we are discussing about inguinal ligament. So how inguinal ligament is formed? Okay, inguinal ligament is formed by the downward. Okay, it is formed by the lower end. Okay, it is formed by the lower end of external oblique, okay, abdominis muscle. It is formed by the lower end of external oblique abdominis muscle. Okay, and this inguinal ligament is attached. It is attached laterally. It is attached laterally to the anterior superior iliac spine, and it is attached medially, to the pubic tubercle. It is attached medially to the pubic tubercle. Okay, it is attached medially to the pubic tubercle. So if you take the attachment of the inguinal ligament, okay, and if you measure the midpoint of it, so what I mean by saying, if you measure the distance between the anterior superior iliac spine and the pubic tubercle, so if I measure a distance between the anterior superior iliac spine and the pubic tubercle, and if I take a midpoint of this is called as midpoint of inguinal ligament. So what is called as midpoint of inguinal ligament? It is the midpoint between anterior superior iliac spine and the pubic tubercle. It is a midpoint between anterior superior iliac spine and the pubic tubercle. Okay, if you take the midpoint between the anterior superior iliac spine and the pubic symphysis, so what is this part? This is pubic symphysis. If I measure the distance between these two, between the anterior superior iliac spine, okay, so if I measure the distance between, okay, the anterior superior iliac spine and the pubic symphysis, then the midpoint of this distance, okay, is called as a mid-inguinal point. This differentiation is very, very important. You should know the difference between the midpoint of the inguinal ligament and the mid-inguinal point. Mid-inguinal point is the midpoint between the anterior superior iliac spine and the pubic tubercle, whereas mid-inguinal point is the midpoint between anterior superior iliac spine and pubic symphysis. Okay, so this difference is very, very important for most of our surface marking. For example, if you want to surface mark the femoral artery, we used to take the mid-inguinal point rather than the midpoint of the inguinal ligament. So of this two, mid-inguinal point is the important landmark. Okay, this is the midpoint of the inguinal region. Okay, this is the midpoint of the inguinal region. Now this inguinal ligament, after gets attached to the pubic tubercle, okay, it forms lot of extensions. Okay, so the first extension, what you see here, okay, you see an extension of the inguinal ligament running posteriorly. Okay, so this extension, what you see here, is called as a lacunar ligament. Okay, it's called as a lacunar ligament. So this this inguinal ligament, after forming the lacunar ligament, it continues along the pubis and along the iliopubic eminence to form a ligament. This extension is called as the pectineal ligament or pectineal ligament of Cooper. It is called as a pectineal ligament of Cooper. Okay, there is also a suspensory ligament of Cooper. Okay, there is a ligament called a suspensory ligament of Cooper, guys. Anybody can tell me where the suspensory ligament of Cooper is seen? So here you see the pectineal ligament of Cooper. Yes, very good. In the mammary gland, in the breast region, you see the suspensory ligament of Cooper. Very good, Daphne John, very good. So here you see the pectineal ligament of Cooper. This pectineal ligament of Cooper is one of the important ligament which is used in inguinal hernia repair. Okay, so for repairing the inguinal hernia, this pectineal ligament is used. Okay, so it is the importance of pectineal ligament. Now from the lateral crest of the superficial inguinal ring, okay, so if you see here, So this is the inguinal superficial inguinal ring. So this is called as a lateral crus. This is called as a lateral crus of the superficial inguinal ring, and from the lateral crus you get a reflection. Okay, you get a reflection, and this reflection is called as a reflected part of the inguinal ligament. So this is called as a reflected part of the inguinal ligament. So these are all the important extensions of the inguinal ligament. So what are all the important extensions? One is called as the lacunar ligament. One is the lacunar ligament. Okay, next one is called as the pectineal ligament of Cooper. Pectineal ligament of Cooper. One is called as a pectineal ligament of Cooper. Then the next ligament what you see here is a reflected part. Okay, it is a reflected part of the crura. Okay, it is a reflected part of the crura of the superficial inguinal ring. Okay, or the reflected part of the inguinal ligament per se. So that forms the extensions of the inguinal ligament. So these are all the important extensions of the inguinal ligament. Okay, all these are arising from external oblique abdominis muscle aponeurosis. Okay, and the nerve supply for external oblique abdominis muscle is, okay, it is supplied by T7 to T11 nerve and by the subcostal nerve. Subcostal nerve is nothing but the T12 nerve. So it is supplied by T7 to T11, okay, nerves. Okay, it is supplied by the thoracic nerves T7 to T11 and by the subcostal nerve. Okay, now with this basics of inguinal ligament, we'll just see what is called as an inguinal canal, how the inguinal canal is formed. Very important topic. Many times questions comes from this area. So next few minutes we'll be dealing with the inguinal canal. So before going into all this diagram, I just need a page, guys. So I'll open a new page for me, so to see what is happening in the inguinal region. Okay, so if I make a cross section of my abdomen at the level of the inguinal canal, okay, so we are going to see about inguinal canal. Okay, so what I'm going to do is I'm going to make a cross section. Okay, I'm going to make a cross section. This is cross section. I make a cross section at the level of my inguinal canal. If I make a cross section at the level of my inguinal canal, see, if you understand this section, guys, okay, see, like in the leg, if you understood the cross sections, okay, it will be very easy to identify or easy to remember the muscles in a very similar way. If you understand this cross section, then it is very easy to understand the inguinal ligament, inguinal canal and its boundaries also. So we'll start with the orientation. So it is a cross section. Now it is a cross section. So when I make a cross section, what you see, first layer, what you see here will be the skin. Okay, the skin of the anterior abdominal wall will be continuous with the skin of the scrotal region. Okay, it will be continuous with the skin of the scrotal. So this is the scrotum. Okay, so this is the scrotum and this is the skin of the anterior abdominal wall. This is the skin of the anterior abdominal wall, and you all know that deep to the skin you got the superficial fascia, okay, superficial fatty layer and the deep membranous layer of scarpa. Okay, so what is the layer which is present here? So the layer which is present here is the superficial fatty layer, and this superficial fatty layer, okay, extends into the scrotum, and there is another layer which is present here. This is called as a membranous layer of scarpa. Okay, these two layers enters into the scrotum, okay, and they form a muscle called as the Dartas muscle. So they form a muscle in this layer which is called as the Dartas muscle. So they form a muscle in this called as Dartas muscle. Okay, so they form a muscle here which is called as Dartas muscle. I hope you know the wrinkling of the scrotum is due to the Dartas muscle. This is called as Dartas muscle. Okay, and what is this layer? What you see here, this is the superficial fatty layer. This is the superficial fatty layer of Camper. Okay, this is the superficial fatty layer of Camper, and this is the superficial membranous layer of the this is a deep membranous layer. This is the deep membranous layer of the scarpa. This is the deep membranous layer of scarpa. Now what happens to both of them in the scrotum? Both of them forms this muscle which is called as a Dartas muscle. Okay, now next to the membranous layer of the scarpa, you encounter this muscle, and this muscle is called as the external oblique abdominis muscle. Okay, external oblique abdominis muscle, when you see here, Okay, so you see this as an aponeurosis. Okay, you see the external oblique abdominis muscle. When it comes to the medial side of the body, when it comes close to the midline, this external oblique abdominis muscle leaves a opening, and this opening is called as what? This opening is called as the superficial inguinal ring. So what is this? This is called as a superficial inguinal ring. Okay, this is called a superficial inguinal ring. And what is this muscle? This is external oblique. Okay, this is external oblique. This is external oblique abdominis muscle aponeurosis. This is external oblique abdominis muscle aponeurosis. Okay, so as you all know, external oblique abdominis muscle aponeurosis has got a opening on the medial side. We saw that here. Okay, we saw that here. So this opening, what you saw here, is the inguinal, is the superficial inguinal ring. We have made a section here. So when you make a section here, okay, when you make a section here, you will have this kind of image where the external oblique abdominis muscle leaves a opening which is called as a superficial inguinal ring, Now from the inguinal ligament, from the lateral 2/3 of the inguinal ligament, okay, so let us consider this is the inguinal ligament. From the lateral 2/3 of the inguinal ligament, okay, so a muscle arises. Okay, so the muscle which arises from the lateral 2/3 of the inguinal ligament, okay, the muscle which arises from the lateral 2/3 of the inguinal ligament is nothing but the internal oblique abdominis muscle. So internal oblique abdominis muscle, where does it takes its origin? A part of the internal oblique abdominis muscle takes its origin from the lateral 2/3 of the inguinal ligament. Okay, so if I want to show this, I'll just erase this area. Okay, I'll just erase this area. Okay, so I'm just removing the external oblique abdominis muscle. Okay, I'm just removing the external oblique abdominis muscle. Okay, I'm removing everything here. So if you see here, I'm just left with the inguinal ligament here. Okay, so from the lateral 2/3, okay, from the lateral 2/3 of the inguinal ligament, okay, and from the middle part of the iliac crest, anterior 2/3 of the iliac crest, there is a muscle which arises and runs in an direction opposite to the external oblique abdominis muscle. See here, the external oblique abdominis muscle are running downwards like this, whereas this muscle is running upwards and medially. Okay, so the internal oblique abdominis muscles are running upward and medially, whereas the external oblique abdominis muscle are running downwards. Okay, so this muscles are running downwards. So this is the direction of external oblique abdominis muscle. The opposite is the direction of the internal oblique abdominis. So internal oblique abdominis muscle is running exactly in the opposite direction. It runs upwards. Okay, so now when this muscle is running here on the lower part of the muscle, okay, it forms a tendon. Okay, it fuses with the transverse abdominis muscle and forms a tendon called as conjoint tendon. So what is this tendon called as? This tendon is called as conjoint tendon. So this conjoint tendon goes and gets inserted into the pubic crest. It goes and gets inserted into the pubic crest. So this is called as conjoint tendon, which goes and gets inserted in the pubic crest. So you say an arching of the fibers. This arching of the fibers is called as a conjoint tendon. Okay, this arching of the fibers is called as conjoint tendon. So if I want to show that in this, so this muscle forms a tendon which is going to the posterior aspect. Okay, so here, so this is called as a conjoint tendon. Okay, so I'll just mark it here. So what is this? This layer is called as a conjoint tendon. This is called as a conjoint tendon. Okay, this is called as conjoint tendon. And what is this layer represents? This layer represents the, okay, so this layer represents the internal oblique abdominis muscle, and this layer represents the external oblique abdominis muscle. Now what happens to these muscles? Okay, so these muscles, they continue as certain fascias. Okay, these muscles continue as certain fascias. We'll discuss about the fascia after discussing about the transverse abdominis muscle. Okay, so now deep to the internal oblique abdominis muscle, you get another muscle. That muscle, again, it takes origin from the lateral 1/3 of the inguinal ligament. So what is this muscle? So the muscle which you see here, is the transverse abdominis muscle. So what is this muscle? This is called as transverse abdominis muscle. And where do this muscle arises from? This muscle arises from, okay, so if you take this muscles, so internal oblique abdominis muscle, it arises from the lateral 2/3 of the inguinal ligament, okay, lateral 2/3 of the inguinal ligament, whereas transverse abdominis muscle, it arises from the lateral 1/3 of the inguinal ligament, 1/3 of the inguinal ligament. But even though they arises from the lateral 1/3 of the inguinal ligament, they arch and they fuse with the internal oblique abdominis muscle to form the conjoint tendon. So how conjoint tendon is formed? Conjoint tendon is formed with the fusion of transverse abdominis muscle plus internal oblique abdominis muscle. It is formed by the fusion of transverse abdominis muscle and by the fusion of internal oblique abdominis muscle. Okay, so this is how the conjoint tendon is formed. Now when you see these muscles they won't stay quiet. They give rise to certain extensions. So what are the extensions? The external oblique abdominis muscle, continues, okay, the external oblique abdominis muscle continues into the scrotum as external spermatic fascia. So it continues into the scrotum as what? It continues into the scrotum as external spermatic fascia. It is called as an external spermatic fascia. So what is this fascia? So this is called as an external spermatic fascia. It is called as an external spermatic fascia. And how this external spermatic fascia is formed? The external spermatic fascia is formed by the external oblique aponeurosis muscle. It is formed by external oblique aponeurosis muscle. Okay, it is formed by the external oblique aponeurosis. Now the next muscle what you see here is the fusion of the transverse abdominis and the internal oblique abdominis. So they join to form they join to form another layer, okay, which has got a muscle in it. So this layer is called as a cremastic fascia. Okay, this layer is called as what? This layer is called as a cremastic fascia. So what is this layer? So this layer is called as a cremastic fascia. This cremastic fascia is formed by the conjoint tendon and by the fusion of the internal oblique and the transverse abdominis muscle. So what is this fascia? This fascia is called as a cremastic fascia. This fascia is called as a cremastic fascia. Okay, so you see conjoint tendon here, okay, and the conjoint tendon also it is continuing inside as the cremastic fascia. Now what is the next layer in the abdomen? So if you see the next layer in the abdomen, so the next layer in the abdomen is the peritoneal layer. Okay, so you get a layer which is you get a layer here which is called as fascia transversalis. Okay, you get a layer called as fascia transversalis. Okay, so this layer is called as fascia transversalis, and this fascia transversalis has got an opening in it. It has got an opening in it. This opening which is seen in the fascia transversalis is called as the deep inguinal ring. It is called as deep inguinal ring. So guys, please remember very important points. Superficial inguinal ring is seen in the external oblique abdominis muscle. Superficial inguinal ring is seen in external oblique abdominis muscle. Deep ring is seen in fascia transversalis. Deep ring is seen in fascia transversalis. So what is this layer, guys? This layer is fascia transversalis. This is called as fascia transversalis. Okay, deep to the fascia transversalis, okay, you have the extra peritoneal pad of fat here, okay, and then you have the peritoneum, so nothing to worry about that. Now you got a ring, okay, on the inner aspect of the abdominal wall, and you got a ring on the outer aspect of the abdominal wall. And if you connect these two rings, okay, this ring represents, or this canal represents the inguinal canal. So this canal represents the inguinal canal. So I am connecting the deep ring with the superficial ring. So superficial inguinal ring is here. So the superficial inguinal ring and the deep ring are connected by a canal. This canal is called as what? Inguinal canal. Okay, if you see the inguinal canal, what are all the structure which lies on the anterior wall of the inguinal canal? You can see throughout the inguinal canal, you can see the external oblique abdominis muscle, and in the lateral part of the inguinal canal you can see the internal oblique abdominis muscle. Okay, here transverse abdominis does not play a role. Okay, so the anterior wall completely it is formed by external oblique abdominis muscle, and on the lateral side it is formed by the internal oblique abdominis muscle. In a very similar way, on the posterior side, medial wall is formed by the conjoint tendon partly. Okay, medial wall is formed by the conjoint tendon partly, and the complete wall is formed by the fascia transversalis posteriorly. Okay, I hope you can able to see this. The entire posterior wall is contributed by the fascia transversalis. The posterior wall on the medial side is contributed by the conjoint tendon. The entire anterior wall is contributed by the external oblique abdominis muscle. Only the lateral part of the anterior wall is contributed by the internal oblique abdominis muscle. So if you understand this section, the understanding of the inguinal canal becomes very easy. Okay, I hope you understood this section, guys. Hope you understood this section. So with this yes, with this we'll go to the inguinal canal boundaries. Okay, so we'll just write down here what are the things you have seen here. Okay, so you see the inlet of the inguinal canal. Where do you see the inlet of the inguinal canal? Yes, guys, you are going to answer for these questions. Where do you see the inlet of the inguinal canal? So this is about inguinal canal. Okay, this is about inguinal canal. Where do you see the inguinal canal inlet? What is the inlet of the inguinal canal called as? So the inlet of the inguinal canal is called as a deep inguinal ring. Very good, guys. It is called as deep inguinal ring. Okay, it is called as deep inguinal ring. And the deep inguinal ring is a defect in, okay, it is a defect in what fascia? It is a defect in fascia transversalis. It is a defect in fascia transversalis. Very good, Anashwara. It is a defect in fascia transversalis. Okay, it is a defect in fascia transversalis. Now you have an outlet for the inguinal canal. Okay, you have got an outlet for the inguinal canal. So what is the outlet for the inguinal canal? It is the superficial inguinal ring. Yes, it is very good, Soumya. Yes, very good, Muga. It is the superficial inguinal ring. It is the superficial inguinal ring. It is the superficial inguinal ring, which is a defect in what muscle? It is a defect in external oblique abdominis muscle. It is a defect in external oblique abdominis muscle. It is a defect in external oblique abdominis muscle. Very good, guys. So this is Prithviraj, very good. So this is about the inlet and the outlet. So inlet is through the deep ring and the outlet is through the superficial inguinal ring. They have got there are certain defects in the corresponding areas. Okay, now coming to the anterior wall, as we have discussed, the anterior wall is formed completely by okay, the anterior wall is formed completely by okay, this anterior wall is formed completely by external oblique. Okay, it is formed completely by external oblique abdominis muscle. It is formed completely by external oblique abdominis muscle. And on the lateral part, okay, and on the lateral part, the external oblique abdominis muscle is forming the complete part of the anterior wall. On the lateral part, it is formed by the internal oblique abdominis muscle. It is formed by the internal oblique abdominis muscle. The posterior wall, okay, the posterior wall, yes, guys, it is completely formed by, can anybody tell me what is the complete part of the posterior wall is formed by? Complete posterior wall is formed by fascia transversalis. Very good, Soumya, Prithviraj, yes, guys, Vinita, very good. So it is formed by fascia transversalis. It is formed by fascia transversalis. Okay, it is formed by fascia transversalis. And on the medial half, okay, and on the medial half, it is formed by the posterior wall. On the medial half is formed or strengthened by this tendon, which is called as conjoint tendon. This is called as conjoint tendon, guys. So on the medial side, okay, on the medial side of the inguinal ligament, it is strengthened by this conjoint tendon. Okay, it is strengthened by the conjoint tendon. You all know what is the roof of the inguinal ligament is. The roof of the inguinal ligament is formed by the arching fibers. Okay, it is formed by the arching fibers, which we saw here. So this arching fibers which you see here is the arching fibers of the transverse abdominis and the internal oblique muscle. Okay, so the roof is formed by the arching fibers. Okay, it is formed by the arching fibers of the transverse abdominis and the internal oblique abdominis muscle plus the transverse abdominis muscle joins to form the roof of the inguinal canal. And the floor of the inguinal canal is formed by, okay, it is the floor of the inguinal canal is formed by, yes, you all know that inguinal canal, the floor is formed by the inguinal ligament, guys. It is formed by the inguinal ligament. So these are all the boundaries of the inguinal canal. Very important topic. MCQs comes frequently from this area. If you understood this topic, then it is it's a very simple topic to crack. Okay, see, inguinal canal, if you see, inguinal canal is a passage okay, which is connecting the deep ring with the superficial inguinal ring. So it is a passage which connects the defect in the fascia transversalis with a defect in the external oblique abdominis muscle. Whenever there is a defect in the anterior abdominal wall, so the structures within the abdomen can come out through this area, resulting in hernias. So inguinal canal is one potential area through which hernias can happen. And if you want to understand the hernia, you need to understand little bit more of anatomy around this inguinal region. So we'll go to the next important part of the inguinal region. Okay, so when you look into the posterior side, when you look into the inguinal canal from the posterior side, you can see this structures. Okay, so what you see here is the rectus abdominis muscle on the medial side. Okay, and from the external iliac artery, you get the inferior epigastric vessels, you got the inguinal ligament below. Okay, so you get a triangle here. This triangle is called as Hasselbalch's triangle. Okay, so Hasselbalch's triangle. So what is Hasselbalch's triangle? So okay, so Hasselbalch's triangle is a triangle which is formed medially by the rectus abdominis muscle, It is formed medially by the rectus abdominis muscle. It is formed laterally by the inferior epigastric vessels. And it is formed below. Okay, it is formed below by the inguinal ligament. Okay, so this area is an area of weakness in the abdominal wall in the inguinal canal. So this area is kept strengthened by the muscles in this area. So if the muscle gets weak, see for example, when the patient becomes obese, fat infiltration takes place in between the muscle layer, so the anterior abdominal wall muscles become weak. So this Hasselbalch's triangle becomes a potential place for hernia. So if a hernia takes place through this, the Hasselbalch's triangle okay, then that triangle or that hernia is called as an direct inguinal hernia. So that hernia is called as what? This is called as direct inguinal hernia. Okay, so if an hernia occurs through the Hasselbalch's triangle, then that hernia is called as direct inguinal hernia. On the contrary, okay, if the hernia occurs through the inguinal canal, okay, how it can occur through the inguinal canal? Through the deep ring. So for that we need to know the contents of the inguinal canal. Okay, so if you see the contents of the inguinal canal contains spermatic cord. Okay, the inguinal canal contains spermatic cord. Okay, and it also contains the ilioinguinal nerve. Okay, so sometimes what happens is, along with the spermatic cord, okay, in the childhood there is a process called as processus vaginalis, okay, which can be seen patent in the canal, when there is a patent processus vaginalis, and hernia can happen through this processus vaginalis. That hernia will pass through the deep ring. So when the hernia pass through the deep inguinal ring, then that hernia is called as an indirect inguinal hernia. So okay, inguinal region, as we are discussing, inguinal region is an area of potential weakness. So if you see the area of potential weakness here, what happens is contents of this abdomen can come out. So that contents, when it comes out, we call that as hernia. There are two kinds of inguinal hernia. One is called as the direct inguinal hernia, another one is called as an indirect inguinal hernia. If the hernia occurs through the Hasselbalch's triangle, then it is called as a direct inguinal hernia. And if the hernia occurs through the deep ring, and if it comes out to the superficial ring, we call it as an indirect inguinal hernia. Okay, and one more important thing is, when the hernia occurs, see if you see a hernia, okay, so hernia is like an outpoaching of the abdominal contents. So it will have a sac and it will have a neck region and it will have a neck region. So this is an hernia picture. Okay, the contents of the hernia can be anything. It can be appendix, it can be small intestine, it can be anything. Okay, so when the hernia happens, it has got a sac and it has got a neck. Okay, if you find the neck of the hernia, okay, if you find the neck of the hernia, if you find the neck of the hernia lateral to inferior epigastric vessels, if you find the neck of the hernia lateral to inferior epigastric vessels, then that hernia is called as an indirect inguinal hernia. Then that hernia is called as what? Then that hernia is called as an indirect inguinal hernia. Then that hernia is called as an indirect inguinal hernia. If you see the neck of the hernia medial to the inferior epigastric vessels, then that hernia is called as a direct inguinal hernia. Then that hernia is called as a direct inguinal hernia. Okay, so when you do an laparoscopy, okay, when you do an laparoscopy, so this point will help you in identifying the type of hernia, which is a direct hernia, which is an indirect hernia, which area we need to strengthen it with the mesh, whether you need to strengthen the posterior wall of the inguinal canal or you need to strengthen the deep ring. So this clue, this orientation of the neck with respect to the inferior epigastric vessels will tell you whether it is an indirect inguinal hernia or a direct inguinal hernia. Okay, see, as I told you, when you put an laparoscopic port into it, okay, into the abdomen, okay, you are very much concerned with the two areas. Okay, you must see two areas very carefully. So one such area is called as triangle of doom. Okay, so one such area is called as triangle of doom. Okay, what is called as triangle of doom? Okay, why it is called as triangle of doom? So doom means death, isn't it or not? Doom means death. Okay, so you should know about the triangle of doom and the triangle of death. Very good, Prithviraj. So what is called as triangle of doom? If you see this picture, okay, if you see this picture, I can draw a triangle here, I can draw a triangle here. So this triangle, okay, is bounded. Okay, this triangle is bounded on one side by the vas difference, and the other side it is bounded by the gonadal vessels. Another side is bounded by the gonadal vessels, and the other side it is bounded by the reflection of the peritoneum. Okay, so this triangle which is formed between these three boundaries is called as triangle of doom. Okay, so if you see the triangle of doom, it is bounded by, okay, it is bounded by, triangle of doom is bounded by the spermatic cord. Okay, it is bounded by the spermatic cord. It is bounded on the lateral side by, so this is the medial boundary, this is the medial boundary, and it is bounded on the lateral side by, okay, so here it is spermatic cord, on the lateral side it is by the gonadal vessels, it is by the gonadal vessels. Okay, okay, it is the lateral boundary of this triangle. Okay, and above, okay, it is bounded by the reflection of the peritoneum, it is by the reflection of the peritoneum above. Okay, it is by the reflection of the peritoneum above. So this three boundaries forms a triangle which is called as triangle of doom. Why it is called as triangle of doom? Because you see here, what is the content of the triangle of doom? Two large vessels are seen in this. What are these two large vessels, guys? The vessel you see here is the external, okay, it is called as the external iliac artery. It is called as the external iliac artery. And what is this vein called as? This is called as an external iliac vein. This is called as an external iliac vein. So this is called as an external iliac vein. So one is called as an external iliac artery, another one is called as an external iliac vein, and this two structures lies in a triangle, and this triangle is called as what? This triangle is called as triangle of doom. Why it is called as triangle of doom? When you put a laparoscopic port, when you operate close to this area, this is where you get the deep inguinal ring. When you operate close to this area, if you inadvertently cut this vessels, just think what happens when such a big vessel gets cut. Lot of bleeding can happen within the abdomen that can result in the death of the patient. That is why it is called as triangle of doom. That is why it is called as triangle of doom, guys. That is why it is called as triangle of doom. Okay, so when you go little bit more lateral, okay, when you go little bit more lateral, you get another triangle here, you get another triangle here. This triangle is called as a triangle of pain. This is called as triangle of pain. Now what are the boundaries of the triangles of pain? Okay, what are the boundaries of the triangle of pain? We'll see what are the triangle formed by. Okay, so if you see the triangle of the pain, it is just lateral to the triangle of doom, and it is bounded again medially by, it is bounded medially by, okay, it is bounded medially by the gonadal vessels, it is bounded medially by the gonadal vessels, and it is bounded laterally by, it is bounded laterally by the iliopubic tract, it is bounded laterally by the iliopubic tract, and it is bounded above by the reflection of the peritoneum again. So peritoneal reflection is seen here, peritoneal reflection is seen here, peritoneal reflection is seen here. This is called as triangle of pain. Why it is called as triangle of doom? Because you got two large vessels, that is called as the external iliac artery and the external iliac vein. So when it gets ruptured, it causes profuse bleeding into the abdomen that can cause death of the patient. Now what is present in the triangle of pain? In the triangle of pain, you have got the femoral nerve, you have got the femoral nerve, and you have got the lateral femoral cutaneous nerve of the, you got the lateral femoral cutaneous nerve of the thigh. So when you damage the nerves, what happens? So damaging of the nerve will result in pain. So that is why this triangle is called as triangle of pain. Guys, if you have seen the femoral triangle in the morning session, okay, if you see the femoral triangle, yes, very good, Prithviraj, the patient can get meralgia parasitica, yes. So if you have seen the femoral triangle in the morning, we have seen about the femoral vessels, and on the lateral side of the femoral vessel you get the femoral nerve, and more laterally you got the lateral femoral cutaneous nerve of the thigh. The same orientation you are seeing from inside now, okay, you are sitting inside the abdomen, and if you see, you will see this kind of orientation. So in this you have got lot of nerves which are running. So this area is called as triangle of pain. This is called as triangle of pain. Okay, so if they give this picture, I hope you can understand what is this triangle called as. Can anybody tell me what is this triangle called as? What is this triangle, guys? What is this triangle called as? This triangle is called as Hasselbalch's triangle. Very good, Hari. It is called as Hasselbalch's triangle. I will put arrow marks in certain areas. Sorry guys, what is this ligament called as? Anybody, what is this ligament called as? This ligament is called as what? This is called as lacunar ligament. Excellent, Hari. It is called as lacunar ligament. It is called as lacunar ligament. Okay, and if you see the lacunar ligament, just lateral to the lacunar ligament, I am putting one more arrow. Can you tell me what is this canal called as? What is this canal called as? Anybody, what is this canal called as, which is seen here? What is this canal? This canal is present on the, I will give a clue, this is present on the medial most aspect of the femoral sheath. It is the medial most compartment of the femoral sheath. What is this canal called as? This canal which is present on the medial most part of the femoral sheath is called as femoral canal. Excellent, guys. Charu, Hari, yes, very good. It's called as femoral canal. Okay, if an hernia occurs through the femoral canal, it is called as femoral hernia. It is called as femoral hernia. This is what we were seeing in the morning. So what you see here is, you have to put your eyes clearly here and see this. You see an artery which is running here. You see an artery which is running here. This artery, okay, is an artery or an anastomosis which connects this one and this artery. Okay, so now what is this artery? Can anybody tell me what is this artery? This artery is called as an inferior epigastric artery. This is called as an inferior epigastric artery. And what is this artery? This artery is an obturator artery. This is called as an obturator artery. Now they are giving a branch, and these branches are anastomosing with one another. And what is this anastomosis? Okay, so this anastomosis is forming here. Okay, so this anastomosis is called as corona mortis. This anastomosis is called as corona mortis. I'll just put a I'll just write it here. So what happens is, so you got an artery running here like inferior epigastric artery. So this is called as inferior epigastric vessels. This is called as an inferior epigastric vessels. Okay, or inferior epigastric artery, and you have an artery running below. This artery is called as an obturator artery. This is called as what? This is called as obturator artery. Now the inferior epigastric artery gives a branch called as pubic branch. The obturator artery also gives a branch called as pubic branch. So you got a pubic branch here, you got a pubic branch here, both of them anastomosis. Okay, both of them anastomosis. This anastomosis is called as corona mortis. This anastomosis is called as what? This is called as corona mortis. Okay, also called as a ring of death. Again when you put the laparoscopic port, when you work on the area, you can injure this vessels. Okay, so that is called as corona mortis. So now what happens to this anastomosis? Usually this anastomosis runs close to the femoral vein. Okay, it runs close to the femoral vein, guys. If you see here, you can see this is running close to this vein. Okay, so the external iliac vein is a continuation of femoral vein, so it is running close to the vein. But sometimes what happens is this vein can run in this area. Okay, so this vein or this anastomosis can run in this area. Okay, so when it runs in this area, okay, we know that when we operate on the femoral hernia, we need to cut the lacunar ligament to enlarge the femoral ring. So if this abnormal artery is seen here, that can cause profuse bleeding again here. So many things are happening around this small area. So a clear cut anatomical detail in this area will help you in avoiding lot of problems in this region. Okay guys, clear? I hope you are clear. Okay, so this ring, what you call or what you see here is the femoral ring. Okay, so what is the ring you see here? This ring, what you see here is the femoral ring. And in the morning we saw femoral ring is formed on the medial side by the lacunar ligament. If you want to reduce the femoral hernia, if you want to take out the femoral hernia, if you want to reduce the femoral hernia, you need to enlarge this ring. Okay, so if you need to enlarge, if you are going to enlarge this ring, if you are going to enlarge the femoral ring, you need to cut the lacunar ligament, guys. You need to cut the lacunar ligament. So when you cut the lacunar ligament, okay, so if an abnormal obturator artery, if an abnormal artery present at that area, then there is a high chance for to injure that artery, that can result in increased bleeding in that area. Okay, so these are all the important applied aspects in this area. So you should know about the inguinal canal boundaries. We have seen about the inguinal canal boundaries. Okay, and we have seen about the problems encountered if there is an weakening of the muscles, or if there is a patent processus vaginalis in this area. You can understand the hernia can happen through this weakened area, or through the patent processus vaginalis, forming an indirect or a direct inguinal hernia. Okay, see, when you have this inguinal canal, okay, so there are certain structure which are passing through the inguinal canal, which you've seen just now. So if you see the structures, okay, so the structure slightly varies between the male and the females. Okay, so in the males, okay, if you see in the males, okay, in the male, okay, the content is mainly the spermatic cord. Okay, the content is mainly the spermatic cord. Okay, along with the spermatic cord, you will have the ilioinguinal nerve. Along with you have the ilioinguinal nerve. You have got the ilioinguinal nerve. Okay, you have got the ilioinguinal nerve. Whereas it is not so in the case of females. In the females, we don't have the spermatic cord. So in the females, instead of the spermatic cord, you have this content. So this is the content of the inguinal canal in the female. So inguinal canal in males, okay, in males it contains a spermatic cord, and in the females it contains a round ligament of the uterus. I hope you know what is called as round ligament of uterus. It is attached to the angle between the fallopian tube and the body of the uterus. Okay, and this round ligament is responsible for maintaining the angle of anteversion. So those things we will see tomorrow morning. So what is called as an angle of anteversion, what is called as an angle of anteflexion, we will see all those things tomorrow morning. But round ligament is one ligament which helps in maintaining the angle of anteversion. Okay, where it is attached at the junction of the fallopian tube and the body of the uterus. So when it comes out through the deep ring through the inguinal canal, and it gets attached to the mons pubis. So finally it gets attached to the mons pubis. Okay, so this is where it is attached. So these are all the contents of the inguinal canal. Now if you take the spermatic cord, if you take the spermatic cord, okay, so if you go back to this diagram, you can see here, you can see the spermatic cord running here, you can see the spermatic cord running here, and it ends in testis, and it ends in testis. And if you see the spermatic cord, you got lot of coverings for the spermatic cord. So all these are the coverings of the spermatic cord, all these are the coverings of the spermatic cord. So if you see the coverings of the spermatic cord, you can appreciate from this diagram, the outermost covering is the external spermatic fascia. So guys, please understand, we have seen this external spermatic fascia is the continuation of external oblique abdominis muscle. It is a continuation of external oblique abdominis muscle. So that is the outermost covering of the spermatic cord. What is the next layer? So the next layer is the cremasteric fascia and the cremasteric muscle. It is the next layer is the cremasteric fascia and the cremasteric muscle. Okay, so this cremasteric fascia and the cremasteric muscle are derived from the fusion of internal oblique abdominis muscle and the transverse abdominis muscle. So cremasteric fascia is derived from the internal oblique abdominis muscle and the transverse abdominis muscle. We have noted that also in the previous discussions. Okay, so cremasteric fascia is formed by this. The next covering is the internal spermatic fascia, which is a continuation of transversalis fascia or fascia transversalis. See, all these are very important MCQs, guys. Very important MCQs. Many times question have come. External spermatic fascia is a derivative of, they will give you 4 choices. Internal spermatic fascia is a derivative of, they will give 4 choices. What we do is, suddenly when we in an hurry in the exam, when we have seen external spermatic fascia, we know that it is external oblique abdominis muscle, and when they ask for internal spermatic fascia, we will suddenly put internal oblique abdominis muscle as the answer. But internal spermatic fascia is derived from where? It is derived from fascia transversalis. It is derived from fascia transversalis. It is derived from fascia transversalis. So these are all the coverings of the spermatic cord. Now what are the contents of the spermatic cord? So you should know the contents of the spermatic cord. So these are all the contents of the spermatic cord. Okay, so the main content of the spermatic cord is the vas deferens, guys. Is the main content is the vas deferens. Okay, so along with the vas deferens, you have the artery and vein to the vas deferens. Okay, that is what you see here. So this is what you see here. So this is the artery to the vas deferens, and adjacent to that are the veins and the lymphatics. Okay, sometimes what happens is a part of the peritoneum comes along with the testis and the spermatic cord, and it forms a small projection here, which is called as processus vaginalis. Processus vaginalis is nothing but it is the tract of peritoneum which comes to the scrotal region, which takes the testis along with it. Okay, so when the testis descends, when the testis descends, it takes the it takes the processus vaginalis, it takes a pouch of peritoneum along with it, that is called as processus vaginalis. Okay, so this is about the contents here. So main content is vas deferens. Apart from these, you have got the testicular arteries, okay, which supplies the testis, testicular vein, which is also called as the pampniform plexus of veins, which carries the blood from the testis, and the sympathetic plexus and the lymphatics are also noted in the spermatic cord. Okay, when you hold the spermatic cord and see, there is not only one content, there are a lot of contents in the spermatic cord. So there are a lot of contents in the spermatic cord. So you got the vas deferens. Okay, you got the vas deferens, main content is vas deferens, and you got the other contents like testicular artery, testicular vein, pampniform plexus. Okay, testicular veins, they don't lie in a single number, it lies in a plexus. So this plexus of veins is called as pampniform plexus. Okay, so along with this, you will also have cremasteric artery and cremasteric vein. Cremasteric artery supplies the cremasteric muscle. Okay, and you also have the genital branch of genitofemoral nerve, which supplies the cremasteric muscle, which supplies the cremasteric muscle. Okay, which supplies the cremasteric muscle. Okay, so this is the this is about spermatic cord, coverings of the spermatic cord and the contents of the spermatic. So on one side you have seen the coverings of the spermatic cord, and the other side you have seen the contents of the spermatic cord. I hope this is a very simple topic, you know this. Okay, so I'm not worried about this. I think you guys will score in this area. Okay, so if we take the inguinal canal, guys, okay, if you take the inguinal canal, you all know that inguinal canal is present on the lower abdominal wall. it is present on the lower abdominal wall. Because it is a defect in the lower abdominal wall, it makes that area slightly weaker, so that can cause hernia. But it is not that all of us are getting hernia, okay, it is not that all of us are getting hernia. So which means that there are some protective mechanisms in the area to prevent the hernia. So what are all the protective mechanisms here? Okay, so protective mechanisms, okay, protective mechanisms in this area, or protective mechanism of the inguinal canal. Protective mechanism of the inguinal canal are, okay, one is called as a shutter valve mechanism. One is called as a shutter valve mechanism. What is called as a shutter valve mechanism? I hope you know, inguinal ligament is below, and above you got arching fibers of the transverse abdominis and the internal oblique abdominis muscle. So you got the inguinal ligament below, which forms the base of the inguinal canal, and above you have the arching fibers of the this okay, arching fibers of the transverse abdominis and the internal oblique abdominis muscle. Now when the transverse abdominis muscle and the internal oblique abdominis muscle contracts, they come and close the inguinal canal like a shutter. So that is called a shutter valve mechanism. That is called a shutter valve mechanism. Shutter valve mechanism is mainly produced by internal oblique abdominis muscle. Okay, it is mainly produced by internal oblique abdominis muscle, and it is also produced by transverse abdominis muscle. It is also produced by transverse abdominis muscle. It is also produced by transverse abdominis muscle. Okay, so the next mechanism which protects the inguinal canal is the slit valve mechanism. Is called as a slit valve mechanism. I hope you know the superficial inguinal ring has got two cruras. It has got two cruras. Okay, so when the external oblique abdominis muscle contracts, the two cruras will close together and it will protect the inguinal canal. So external oblique abdominis muscle contraction, acts like a slit to close the ring. That is called a slit valve mechanism. Next is called as a ball valve mechanism. So there is a mechanism called as ball valve mechanism. So what is called as ball valve mechanism? So you know that the spermatic cord is lying in the scrotum with the testis hanging to it, and this is covered by the cremasteric muscle. Okay, so when the cremasteric muscle contracts, okay, when the cremasteric muscle contracts, it pulls the testis to the superficial inguinal ring. Okay, it pulls the testis to the superficial inguinal ring. Okay, to the superficial inguinal ring, thereby it closes the ring. So this mechanism is called as ball valve mechanism. This is called as ball valve mechanism. So what does it do? So when the cremasteric muscle contracts, since it is surrounding the spermatic cord and the spermatic cord is attached to the testis, it pulls the testis above, and the testis comes and closes the superficial inguinal ring, thereby preventing the inguinal hernia to happen. So this mechanism is called as ball valve mechanism. Okay, so these are certain protective mechanisms around the inguinal canal. Okay, so these are certain protective mechanisms around the inguinal canal that prevents the hernia to happen. Okay, so when you know about this, I think this finishes, or this completes the inguinal region, guys. This completes the inguinal region. Okay, so we have done with the main part of the introduction to the abdomen, that is the inguinal region. So we'll just take a short break, okay, 5 minutes or 10 minutes, then we'll come back and we'll see the rest part of the abdomen. Okay, we were discussing about the inguinal canal, inguinal ligament, and the inguinal hernia. Okay, so now we'll be seeing about the liver. Okay, so we are going to the viscerals. So before going into the liver, okay, which is given in the workbook, I just need a small page. I'll just open a small page so that I can draw a diagram to show you what is happening around the liver. Then we'll go to the workbook. Okay, so if you see here, liver, okay, is an organ which is present in the abdomen on the right quadrant. Okay, so you all know that the abdomen is divided into, okay, 9 quadrants. So let us consider this is the costal margin, okay, and this is the hip bone region, okay, pelvic bone region. So you divide the abdomen into 9 quadrants. Okay, divide the abdomen into 9 quadrants. Okay, so the liver occupies, okay, the liver occupies, okay, the liver occupies these 3 quadrants mainly. This liver occupies these 3 quadrants mainly. And what are these 3 quadrants represent here? This quadrant represents the, okay, this quadrant represents the right, okay, it represents the right hypochondriac region. It represents the right hypochondriac region. Okay, and this quadrant represents the umbilical region, epigastric region. This represents the epigastric region. Okay, and this represents the left hypochondriac region. This represents the left hypochondriac region. This represents the left hypochondriac region. Okay, so you got 3 regions which are occupied by the liver. So the lobes or the liver occupies left hypochondriac, epigastric and the right hypochondriac region. Okay, so if you see this, the right hypochondrium is predominantly engulfed by the liver. It is predominantly occupied by the liver. Okay, so it is predominantly occupied by the liver. So when you see about the liver, liver is an peritoneal organ. So what is this organ? This is an peritoneal organ. So if it is an peritoneal organ, so it is covered by the peritoneal organ on most of its sides. It is covered by peritoneal organ by peritoneum by on most of its sides except few areas. So we'll come to that later. So liver is an organ. Okay, liver is an organ which is one of the largest organ in the body and which stores lot of glycogen in it. So these are all small things which we have studied from our earlier days. Okay, but when we come to the proper anatomy of the liver, okay, so what are all the things that are related here is, see, one is the relations and the surfaces of the liver. Okay, one is the relations and the surfaces of the liver. So what are all the surfaces of the liver? As liver has got 5 surfaces, guys. Liver has got how many surfaces? It has got 5 surfaces. Okay, if I want to draw a simple schematic diagram, okay, so let us consider this is a small triangle. So liver has got a triangular shape. Liver has got a small triangular shape. Okay, it has got 5 surfaces. Okay, so the 5 surfaces are, this is one. Okay, so this is one surface. This is the next surface. Let us consider 2, 3, and this is the 4th surface, and the one which you see behind is the 5th surface. So what are the 5 surfaces? So what you see above is called as a superior surface. This is called as a superior surface. One is the superior surface. 2 represents, okay, 2 represents the inferior surface. 2 represents the inferior surface. Okay, 2 represents the inferior surface. 3 represents the right lateral surface. Right lateral surface. Right lateral surface. Okay, 4 represents, okay, the 4 represents the anterior surface of the liver. Anterior surface of the liver. And the last one, that is the 5th one, represents, okay, the inferior surface of the liver. Sorry, the 5th one represents the posterior surface of the liver. This is the posterior surface of the liver. This is the posterior surface of the liver. If you take these 5 surfaces except one surface, except one surface, except the inferior surface, okay, all the other surfaces are related to the diaphragm. So all the other surfaces except the inferior surface, all other surfaces are related to the diaphragm. Okay, related to the diaphragm. So that is why those surfaces are called as diaphragmatic surfaces. That is why those surfaces are called as what? Diaphragmatic surface. So they are called as diaphragmatic surfaces. They are called as diaphragmatic surfaces. And the surface which is related to the visceral organs. Okay, so the inferior surface is related to the viscerals. So that is called as a visceral surface. We call this as a visceral surface. So how many surfaces are? So there are 5 surfaces. Broadly we can divide the liver into diaphragmatic surface and inferior surface. So the anterior, superior, posterior and right lateral surfaces are diaphragmatic surface, whereas the inferior surface, which is mainly related to the visceral organs, forms the visceral surface, forms the visceral surface. Okay, so if you see the liver, guys, if you see the liver, so the liver is located, as you have seen, it is located in the right hypochondriac region mainly. Okay, it is also extending across the epigastric and the left hypochondriac region. Okay, so you have the ribs on the sides. Okay, so you have the ribs on the sides. So the ribs and the lungs and the pleura are all separated by this covering. So this covering is nothing but the diaphragm. So this is diaphragm. So this is diaphragm. Okay, so this is diaphragm. Now the liver is related to the stomach below. So below you have the stomach here. Below you have the stomach here. Okay, below you have the stomach here, and the liver is connected to these areas by means of lot of peritoneal folds. So what are all the peritoneal folds around the liver? Okay, so the peritoneal folds around the liver are, okay, the peritoneal folds around the liver are, so if you see the right lobe of the liver is connected to the diaphragm above. It is connected to the diaphragm above. This fold of peritoneum which connecting the right lobe of the liver to the diaphragm is called as the superior layer of the coronary ligament. So what is this? One is called a superior layer of coronary ligament. It is called a superior layer of the coronary ligament. It is called as a superior layer of the coronary ligament. Okay, and on the lateral side the liver is connected to the diaphragm by means of a triangle shaped ligament. This ligament which is seen on the lateral side is called as the right triangular ligament. This is called as a right triangular ligament. This is called as a right triangular ligament. And on the left side the liver is connected to the diaphragm by means of a triangular fold of peritoneum. Okay, so this triangular fold of peritoneum connecting the liver and the diaphragm. Okay, so that represents the left triangular ligament. So this is the left triangular ligament. So what is this? This is the superior layer of the coronary ligament. And what is this? This is the right triangular ligament, and this is the left triangular ligament. These are all the ligaments which are connected to the liver, to the sides and to the above. What is present below? So if you see below, the liver is connected to the stomach and to the first part of the duodenum. It is related to the stomach and to the first part of the duodenum. Okay, it is related to the stomach and to the first part of the duodenum by means of this peritoneal fold which is called as the lesser omentum. Okay, this is called as the lesser omentum, guys. So this is called as the lesser omentum. Okay, this is called as lesser omentum. So lesser omentum is extending from the liver to the stomach and to the first part of the duodenum. So I'll just draw it in a different color to the first part of the duodenum. So the lesser omentum is divided into two parts here. The one which is running from the liver to the stomach, and one that is running from the liver to the duodenum. Okay, so that is called as an hepatogastric part. So this is called as, okay, so this part is called as an hepatogastric part, and this part is called as a hepatoduodenal part. This is called as an hepatoduodenal part. Okay, clear? So both are the parts of lesser omentum. So guys, what you need to observe here is, so this is the right side of the abdomen, this is the left side of the abdomen. If you see the lesser omentum, the right margin of the lesser omentum is free. Okay, so the right margin, the right margin of the lesser omentum is free here. Okay, the right margin of the lesser omentum is free here. That is the main thing you need to observe here. Lot of things happens in that area. We'll discuss that when we come to the peritoneum. So as of now, the liver is surrounded in the lateral side by the right triangular ligament. Superiorly, it is related to the superior layer of the coronary ligament on the right side, and on the left side, if you see, you got the left triangular ligament under the lesser omentum inferiorly. Okay, now I will just take the use of another diagram, okay, to show you one more ligaments here, few more ligaments here. So the fourth one what we saw is the lesser omentum, guys, is the lesser omentum. Now if I make another simple diagram, when you see the liver from the side, okay, let us consider this is the anterior abdominal wall. Okay, so this is the anterior abdominal wall, and I hope you know this is the diaphragm which is separating the thorax from the abdomen, and below the below the diaphragm you get the liver here, you get the liver here. Okay, you get the liver. Now you can see this is the anterior side and this is the posterior side of the liver. Okay, this is the posterior side of the liver. Okay, so this surface is called as the posterior surface. This is called as the posterior surface of the liver. This is called as the posterior surface of the liver, and there is an fold of peritoneum which extends between the anterior abdominal wall to the liver. Okay, so this fold of peritoneum which extends from the anterior abdominal wall to the liver is called as the falciform ligament, guys. Is called as the falciform ligament. Okay, so what is this ligament? This ligament is called as the falciform ligament. So this is called as falciform ligament. It is a sickle shaped ligament. It is a sickle shaped ligament. Okay, the one end is attached to the liver, the other end is attached to the umbilicus. So it is other end is attached to the umbilicus, other end is attached to the umbilicus. Okay, so here again if you see the lower border of the falciform ligament is free. So the lower border is free here, the lower border is free here, and in the lower border which is free there runs an obliterated vein to the liver, there runs an obliterated vein to the liver. Okay, and this vein which is running to the inferior surface of the liver which is obliterated is nothing but the ligamentum teres hepatis. It is called as ligamentum, it is called as ligamentum teres hepatis. It is called as ligamentum teres hepatis. Teres means round. Can anybody tell me where we saw ligamentum teres? One more ligamentum teres we saw in the morning session. Where do you see ligamentum teres, guys? Did you saw ligamentum teres anywhere? Okay, anybody? Yes, very good. It is seen in the head of the femur which is connected to the fovea capitis. Okay, I didn't told one point there. Okay, so you can see the ligamentum teres in the head of the femur. It is attached to the head of the femur. Can anybody tell me what is the attachment of the ligamentum femur to the other side? Okay, so just to add a small point here. Okay, guys, just to add a small point, this is the head of the femur. Okay, yes, accepted. This is fovea capitis, and you get a ligament here. What is this ligament? What is this ligament? This is called as ligamentum teres hepatis. Okay, this sorry, ligamentum teres. This is called as ligamentum teres. Can anybody tell me what is the point of attachment to the other side? Point of attachment to the other side. Ligament bridging the ends of acetabular fossa. Very good, Anashwara. What is that ligament called as? So the acetabular fossa, the ends of the acetabular fossa are bridged by a ligament. It is running transverse in the acetabulum. So I have given a clue. So that is called as transverse acetabular ligament. So this is called as transverse. This is called as transverse acetabular ligament. This is called as transverse acetabular ligament. This is called as ligamentum teres femoris. This is called as ligamentum teres femoris. Now we are discussing about the ligamentum teres hepatis, and this ligamentum teres hepatis is running in the lower free border of the falciform ligament, and then it runs in the inferior surface of the liver. And then it runs in the inferior surface of the liver. Okay, it runs in the inferior surface. Now if you trace the falciform ligament, this splits and surrounds the liver. Okay, so when you come more to the lateral side, when you come more to the lateral side, okay, so this peritoneum gets reflected to the diaphragm like this. This reflection of the peritoneum which you see here is called as a superior layer of the coronary ligament. This is called as a superior layer of the coronary ligament. And what is happening to the part of the peritoneum below? Okay, if you see the liver, below the liver to the right side, you get an important structure which is located. Okay, this structure which is located below the liver is called as a kidney. Okay, this is called as kidney. Situated above the kidney is an yellowish color structure which is called as the okay, this is called as a suprarenal gland. This is called as a right suprarenal gland. Okay, if you see the peritoneum after covering the inferior surface of the liver, it reflects over the anterior surface of the kidney. This reflection is called as the inferior layer of the coronary ligament. This reflection is called as the inferior layer of the coronary ligament. This is called as the inferior layer of the coronary ligament, and this reflection in this area forms an important pouch. Can anybody tell me what is the pouch which is formed here between the liver and the renal gland? Okay, liver and the kidney, Okay, Morrison's pouch, very good. It is called as hepatorenal pouch of Morrison. It is called as hepatorenal pouch of Morrison. It is called as hepatorenal pouch of Morrison. What is the importance of hepatorenal pouch of Morrison? So when a patient is lying supine, okay, when a patient is lying supine, okay, so in and supine patient, okay, in and supine patient, this is the most dependent area. This is the most dependent part of the peritoneal cavity. Most dependent, okay, it is the most dependent part. It is the most dependent part of the peritoneal cavity. It is the most dependent part of the peritoneal cavity. So if somebody asks you if the patient is in supine, okay, yes, Morrison's pouch is the most dependent pouch. But if the patient is standing, okay, if the patient is standing, what is the most dependent pouch, guys? When a patient is standing, what is the most dependent pouch of the peritoneum called as? Anybody? What is the most dependent pouch when a patient is in erect posture or when the patient is standing? So when the patient is lying, yes, accepted. Morrison's pouch, yes, very good. It is the pouch of Douglas. Very good, Monisha, Soumya, very good. Yes, Adira, it is the pouch of Douglas. So when the patient is lying supine, the hepatorenal pouch is the most dependent part. When the patient is lying erect or when the patient is erect, it is the pouch of Douglas, which is the most dependent part. And when you see the liver here, okay, the posterior surface of the liver, okay, the posterior surface of the liver, you don't see the peritoneum. You see the peritoneum on the anterior surface, you see the peritoneum on the superior surface, you see the peritoneum on the inferior surface, but on the right side, okay, on the right side, the posterior part or the posterior portion of the liver is not surrounded by this peritoneum. So this area which you see in the posterior surface is called as the bare area of the liver. It is called as the bare area of the liver. So where is bare area of the liver located? It is located on the posterior surface. It is located on the posterior surface, okay, and it is not covered by the peritoneum, and this part comes in contact with the diaphragm, okay. So if you see the diaphragm here, so this is diaphragm, okay, so this is diaphragm, and this diaphragm comes in contact with the posterior surface of the liver, posterior surface of the liver, okay, posterior surface of the liver can comes in contact with the diaphragm. This is called as the bare area of the liver, okay. So these are all certain peritoneal reflections here. So what are the other peritoneal reflections we need to add here? So the fifth one will be the inferior layer of the coronary ligament, inferior layer of the coronary ligament, inferior layer of the coronary ligament is the fifth one, okay. So I'll just put a slash here, and the sixth one will be the falciform ligament. Sixth one will be the falciform ligament. So these are all the important peritoneal folds which are related to the liver. These are all the important peritoneal folds which are related to the liver, okay. See, as we have seen already, the anterior surface, the superior surface, the right lateral surface are all covered by the diaphragm, and this diaphragm separates these surfaces from the structures like lungs, structures from the pericardium, structures like pleura, in all these areas. So most important relationship in the liver is the inferior surface, okay, which is called as the visceral surface, okay. So if you want to know the visceral surface relationship, okay, we'll just choose this diagram. So we'll know this surface as the inferior surface, okay. So what you see here, this surface is the posterior surface, okay. How I say this is posterior surface? Because I can see an area which is devoid of the peritoneum. So this is the bare area of the liver. This is the bare area of the liver, okay. The reflection of the peritoneum, what you see here is the right triangular ligament. This is called as the right triangular ligament. This is called as the right triangular ligament. And the reflection of the peritoneum, what you see here is the left triangular ligament. This is called as the left triangular ligament, okay. This is called as the left triangular ligament, okay, guys. So this is called as left triangular ligament, okay, fine. So this is called as the bare area of the liver. So what you are seeing is the bare area of the liver. Now when you see the inferior surface of the liver, okay, when you see the inferior surface of the liver, I can able to appreciate some part of the posterior surface also, isn't it or not? I can able to appreciate some part of the posterior surface also. So we'll just take together as postero-inferior surface and we'll discuss this picture. So we'll take this as postero-inferior surface and we'll discuss this picture, and what you see in the posterior surface is the IVC. So the structure which you see here is IVC. The structure which you see here is IVC, okay. Just medial to the force of our IVC, okay, you get a fissure, This fissure what you see here is called as the fissure for ligamentum venosum. This is called as a fissure for ligamentum venosum. Okay, so you all know ligamentum venosum is a remnant of ductus venosus. It is called as ductus venosus. Okay, fissure for ligamentum venosum contains ligamentum venosum here. In between the fissure for ligamentum venosum and the IVC, you get a lobe. This lobe is called as a caudate lobe. This lobe is called as a caudate lobe, and this caudate lobe is separated from the quadrate lobe by means of this area. This area is called as porta hepatis. What is this called as? This is called as porta hepatis. So what do you mean by porta? Porta means it is the entry point. So the structure, whether it enters the liver or if it goes out of the liver, it mainly uses this entry point. So this area is called as a porta hepatis. Okay, so in the posterior surface of the liver, you get the caudate lobe, you get the fissure for ligamentum venosum, you get the fossa for gallbladder, and you get the Barr area. So we'll write here. So what are the things you see in the posterior surface of the liver, guys? In the posterior surface of liver, so in the posterior surface of the liver, I can get the Barr area. Okay, I can get the Barr area. I can get the fossa for IVC. I can get the caudate lobe here. I can get the caudate lobe here, and just medial to the caudate lobe, I get a fissure, and this fissure is called as fissure for ligamentum venosum. This is called as fissure for ligamentum venosum. Okay. Now coming to the inferior surface, guys. Coming to the inferior surface. Okay. This inferior surface again has got a fossa like the posterior surface, and this fossa is called as the fossa for gallbladder. This is called as the fossa for gallbladder, which lodges the gallbladder in it. Which lodges the gallbladder in it. Just medial to the fossa for gallbladder, you get a lobe. This lobe is called as a quadrate lobe. Okay, this lobe is called as a quadrate lobe, and just medial to it, okay, you get a fissure, and this fissure is called as fissure for ligamentum teres. It is called as fissure for ligamentum teres hepatis. It is a fissure for ligamentum teres hepatis, which lodges the ligamentum teres per se, Now again the quadrate lobe, okay, is separated from the caudate lobe by porta hepatis. Okay, so when you see the inferior surface, you can see lot of elevations and depressions, which are nothing but the impressions created by the visceral organs. Now what are the impressions which are seen here? So the impressions what you see here are, so you see the gastric impression in this area. Okay, you see the gastric impression in the area. Okay, so this impression is the gastric impression. Okay, this impression is called as a gastric impression. Okay, and you all know that stomach becomes the pylorus, and pylorus becomes the duodenum. So the pylorus becomes the duodenum here. So this is the duodenal impression area. This is the duodenal impression. This is where you get the duodenal impression. Okay, and this duodenal impression continues here, and this impression what you see here is the right hepatic flexure impression. This is the impression of the right hepatic flexure. Okay, so you know that ascending colon becomes a transverse colon. Okay, so that flexure which is present below the liver is called as a right hepatic flexure. So on the right hepatic flexure is present in the, or the right hepatic impression is present here. Okay, so this is the impression of the right hepatic flexure, and slightly behind is the impression of the renal gland. So this is the right kidney. So this is the impression of the right kidney here. So these are all the important things, and you also get the impression of the right suprarenal gland here. This is the right suprarenal gland here. So these are all the structures, or these are all the organs, visceral organs, which are related to the inferior surface of the liver. So you get gastric impression. The gastric impression continues as the duodenal impression, pyloric impression, and the duodenal impression. Then you get the right hepatic flexure impression, and you get the kidney and the suprarenal impression. So these are all the important impressions which are seen in the liver. Okay, these are the important structures which are related to the liver. See, when you take the liver, okay, so liver has got a huge blood supply. Okay, so what is the blood supply for the liver? So the blood supply for the liver is by two main vessels. Okay, so you got two main vessels. Okay, one vessel is the hepatic artery. One vessel is the hepatic artery. We'll discuss about the vessels in a short while. Okay, if time permits, or tomorrow we'll discuss about this. The hepatic artery carries 20% of the blood to the liver. The remaining 80% of the blood is carried by this vein, which is called as portal vein. So which carries the 80% of the blood to the liver, which carries 80% of the blood to the liver. Okay, and the veins are the venous drainage of the liver. Okay, so if you take the venous drainage of the liver, okay, if you take the venous drainage of the liver, okay, liver is drained by a vein called as hepatic veins. Okay, it is drained by a vein called as hepatic vein. Okay, there are two groups of hepatic veins, upper and lower. So usually the uppers are divided into the superior, middle and inferior. Okay, so you got superior, or we can write like this. Okay, so right, okay, you can write like this. So right, middle and left hepatic veins. These are all the hepatic veins which are seen, and these hepatic veins drain the liver into IVC. So how the blood supply reaches the liver? So the arterial supply is only 20% through the hepatic artery. The nutritious rich blood is carried from the intestine through the portal vein, which gives 80% of the blood supply to the liver. Okay, and the venous drainage is by the hepatic veins. Okay, there are 3 set of hepatic veins, and these hepatic veins opens into the IVC. So if you see the hepatic artery and the portal vein, they enter into the liver through porta hepatis. So if you take the porta hepatis, guys, if you take the porta hepatis, so the structures which are running through the porta hepatis are very, very important. So we have seen 2 structures. So one is the right and left branches of hepatic artery. Okay, right and left branches of hepatic artery, and the right and the left branches of portal vein. The right and left branches of portal vein. Okay, the right and left branches of the portal vein, and you also get the right and the left branches of the hepatic ducts. Okay, the hepatic ducts, right and left hepatic ducts come out and they join together to form the common hepatic duct. So porta hepatis allows the passage of these 3 structures. And in what order these 3 structures are arranged? If you go in the porta hepatis from anterior to posterior, you can remember this by a mnemonic called as, okay, so we'll go like this. Yes, we'll go like this. Okay, we'll go from posterior to anterior so that the mnemonic will work easily. So when you go in the porta hepatis from posterior to anterior, you got the VAP structure. Okay, you got the VAP structure where we call the resonant VAD structure. Okay, V stands for the portal vein. So when in the porta hepatis, if you go from the posterior to the anterior side, okay, so see here, you go from this is the posterior side and this is the anterior side, posterior surface here. So this is the posterior side. When you go from the posterior to the anterior side in the porta hepatis, you have the VAD arrangement. What is the VAD arrangement? V stands for portal vein, A stands for hepatic artery, and D stands for the bile duct or the hepatic ducts. Okay, this is the hepatic ducts. So this is the relationship of the structures in the porta hepatis, which is again important. So when you go in the porta hepatis from the posterior to the anterior side, you have got the portal vein, you got the hepatic artery, and you got the hepatic duct, guys. You got the hepatic duct. Okay, so this is about the liver, this is about the attachments of the liver, this is about the relationship of the liver. But very, very important point is the segments of the liver. Okay, see, normally how do you divide the liver? Okay, so you divide the liver, okay, anatomically. You divide the liver anatomically into 2 lobes. One is called as the right lobe, another one is called as the left lobe. Right lobe is larger and the left lobe is small. And how do you divide this? This is divided by the attachment of okay, it is divided by the attachment of falciform ligament. Okay, but this anatomical classification of the liver into right lobe and left lobe is not of much use, guys. So surgically, whenever you apply things, that becomes more value. So when you are going to apply the classification of anatomical classification for the liver, it doesn't work. So what you require is a functional classification. So liver is classified functionally by a person called as Cuignard. Okay, so Cuignard classification of the liver segments is based on the lobe that receives the three things. Okay, so Cuignard divided the liver into 8 segments. He divided the liver into 8 segments based on their portal vein branch, based on their bile ductile branch, and based on their hepatic vein branch. So based on these three, if a segment has got these three, so portal vein radical, bile ductile radical, and an hepatic vein radical, so that lobe can act as a separate lobe and that can be easily resected. This is the idea behind Cuignard. So for that, he used an imaginary line called as Cantel's line. He used an imaginary line called as Cantel's line. So that is the line what you see here. So this line is called as Cantel's line. This line runs from the Cantel's line. So Cantel's line runs from the fossa for it runs from the fossa for gallbladder. It runs from the fossa for gallbladder to the groove for IVC. It runs from the fossa for gallbladder to the groove for IVC. So this line is called as Cantel's line, and they take this fissure as the main portal fissure. So they take this fissure as the main portal fissure. So what is this fissure? So you see a fissure here. This fissure is called as the main portal fissure. This is called as main portal fissure. This is called as main portal fissure. So this main portal fissure divides the liver into two big lobes. One is the right lobe and another one is the left lobe. Now the right lobes are further divided into a fish into the right lobes are further divided into the right lobes are further divided into right portal fissure. Divided into right portal fissure. So the right portal fissure divides the right lobe into two segments, and the left lobe is divided by means of an left portal fissure, which is also called as an umbilical fissure. It is also called as an umbilical fissure. Okay guys, it is also called as an umbilical fissure. So now if you see, the liver has got three main fissures. One is the main portal fissure, the right portal fissure, and the left portal fissure. The left portal fissure is also called as umbilical fissure. The left portal fissure is also called as what? It is also called as umbilical fissure. Okay guys, so these fissures divides the liver into 8 segments, and if you number the 8 segments from clockwise direction from the left to the right, so the caudate lobe receives the number 1. The left superior segment, the left lateral superior segment receives number 2. The left medial superior segment receives the number 2. And the left medial inferior segment receives number 3. The left main segment receives the number 4, and 5, 6 and 7, 8 comes in a clockwise direction. So you number them from left to the right in a clockwise direction, and they become the functional lobes of the liver. So this is about the functional division of the liver. So how Cuignard divided? He used the major fissures to divide the livers. So the major fissure is drawn by this Cantel's line. We know the Cantel's line, and it divides the liver into Cantel's line divides the liver into right lobe and left lobe. So all these are functional lobes, right lobe and left lobe. So is the right functional lobe, and there is a left functional lobe, and the functional right lobe is further divided into 2 by means of a right portal fissure, and the left is divided into 2 segments by means of a left fissure, which is also called as an umbilical fissure. Which is also called as what? Which is also called as an umbilical fissure. So okay, so if you take the right functional lobe, what are the segments which are present in the right functional lobe? You have the 5th segment, you have the 6th segment, you have the 7th, and you got the 8th segment here. Whereas the left functional lobe has got segment number 1, which is the caudate lobe. So this is the caudate lobe, okay, and you got the segment 2, segment 3, and segment 4 in the left functional lobe. Okay, so please be clear, each of this has got individual portal veins, they have got individual hepatic veins, and they got individual bile duct radicle. So they got the individual portal triad along with them. The only exception is caudate lobe. Caudate lobe drains into both the right and the left hepatic veins. It drains into both into the right and the left hepatic veins. It does not, see, usually the right side, all this, they drains only into the right hepatic veins. Okay, they drain into the right hepatic vein. Okay, and they drain into the left hepatic veins. They drain into the left hepatic veins. But if you see the caudate lobe alone, it drains both into the right and the left hepatic vein. Okay, so it drains into both into the right and the left hepatic vein. This is about the functional lobes. Okay, so functional lobes, you can name them, so that is what the numbers are given here. So this is called as, okay, the 5th. You see, you can keep this as the anterior segment. So this is anterior segment and this is anterior segment. This is present on the right side, so this is right. Okay, this is right. So this is the 5th one. This is right inferior anterior segment. This is right inferior anterior segment. 6th is the right, okay, inferior posterior segment. 5th is nothing but the right inferior posterior segment. The 7th, which is seen here, it is the right, okay, right superior posterior segment. It is called as the right superior posterior segment. Okay, so these segments are more anterior and these segments are more posterior, so we are giving the term posterior for it. The 8th segment is called as the right, okay, right superior anterior segment. It is called as the right superior anterior segment. Okay, so you can name them. This is not that difficult. Once if you understand the orientation of the segments, it is very easy. So don't confuse much. So the concept is very simple. Anatomically, you divide the liver into left lobe and right lobe by means of the attachment of the falciform ligament, but that is not useful for anything, because when you are going to surgically resect, you can surgically resect one particular small area which has got all the 3 supply. That comes the role of functional classification by Cuisinart. Okay, so if you see the second lobe, okay, if your second lobe is seen here, and this the second lobe is called as the left, okay, left superior, okay, and this is called as the left inferior, okay, left inferior. So this is left superior medial segment and this left inferior medial segment, and 4th is called as the left lateral segment. The 4th is called as the left lateral segment. Okay, so these are all the segments or the functional segments of the liver. Okay, so this is about the classification by Cuisinart, and this is about the liver. Okay, so when you see the liver, the main function of the liver is to store the glycogen, and one more important function is to produce an important digestive enzyme that is called as bile. Okay, so we are going to see about the bile and the collection of the bile now. So before that, they have given some point here. The quadrate lobe receives blood from the hepatic artery and it drains bile into the left hepatic duct. Okay, it is a very simple lobe, but what is head? It is caudate. Okay, so this is the lobe. Okay, the caudate lobe, if you see, it receives blood from right and left hepatic artery and it drains both the right and left hepatic ducts, and it drains biles into both into the, so caudate lobe is one peculiar lobe. Okay, it is one peculiar lobe. So it receives blood both from the right and left hepatic artery, and it is receives and it drains the blood and the bile into both the hepatic ducts and both the hepatic veins. So that is the speciality about the caudate lobe. Okay, so coming to the next topic of today's evening is the extrahepatic biliary apparatus. Okay, I hope you all know that the main function of the liver is also production of the bile. Bile is one of the digestive enzyme which reaches the gut and helps in digestion of the emulsification of the fat. So this bile is produced in the liver, but though it is produced in the liver, it is concentrated and stored in this organ which is called as gallbladder. So what is the function of gallbladder, guys? Gallbladder not only stores, okay, it also concentrates the bile. It also concentrates the bile. And where is gallbladder situated? It is situated below the liver. In which surface? It is present below the liver in the inferior surface. So in the inferior surface there is a fossa for gallbladder which is occupied by the gallbladder. And if you take the gallbladder has got certain parts. This is called as the fundus of the gallbladder. This is called as the body of the gallbladder. Okay, this is called as the body of the gallbladder. This is called as the neck of the gallbladder. Okay, if you see the fundus of the gallbladder, okay, this fundus of the gallbladder lies between the ninth costal cartilage, in the angle between the ninth costal cartilage. Okay, it lies in the angle between the ninth costal cartilage and the lateral border of okay, rectus abdominis muscle. Okay, so it lies in an angle between the ninth costal cartilage and the rectus abdominis muscle. Okay, so if you see the ninth costal cartilage and the rectus abdominis muscle, the fundus of the gallbladder is situated here, and there is a condition called as cholecystitis. What is cholecystitis? Cholecystitis is inflammation of the gallbladder. Okay, cholecystitis is inflammation of the gallbladder. So when the gallbladder gets inflamed, okay, so it is called as cholecystitis. And when a patient has got cholecystitis, okay, when you press, okay, in the angle between the ninth costal cartilage, okay, in the angle between the ninth costal cartilage and the lateral border of the rectus abdominis, the patient will have severe pain, and that sign is called as Murphy's sign. And that sign is called as what? That sign is called as Murphy's sign. Okay, that sign is called as what? That sign is called as Murphy's sign. I hope you all know this sign. So this sign is called as Murphy's sign. Okay, so there is a kid called as Murphy's kid. Okay, can anybody tell me where you get Murphy's kid? Yes, guys, where you get Murphy's kid? There is a instrument in again in ortho. So there is an instrument called as Murphy's kid. Can anybody tell me where it is used? Murphy's kid. So Murphy's kid is used in orthopedics while doing arthroplasty of the hip. Okay, while doing the arthroplasty of the hip region, we use this. Okay, so that is called as Murphy's kid. Okay, so when you see the gallbladder, the fundus of the gallbladder, okay, the fundus of the gallbladder lies between the ninth costal cartilage and the lateral border of the rectus abdominis. So that is called as an area where you get a cholecystatic tenderness. That sign is called as Murphy's sign. Okay, yes, Ashish, I think you have got a doubt, so I'll try to rectify the doubt, okay, in the latter part of the class. Okay, so so there is a sign which is called as Murphy's sign. Okay, so when you see the gallbladder, the body of the gallbladder then continues as the neck of the gallbladder. Within the body of the gallbladder, you got mucosal folds. Okay, so you got foldings which are called as the mucosal folds, and when it reaches the neck dilates here to form a pouch. This pouch is called as Hartmann pouch. So this is called as an Hartmann pouch. Sometimes stones can get lodged in the Hartmann's pouch, and it can occlude the outflow of the bile, Okay, so when you see the neck of the gallbladder, you see this pouch. This pouch is called as Hartmann's pouch, and this gallbladder from the neck leads into a duct. Okay, so this duct is called as the cystic duct. What is this duct called as? So this duct is called as a cystic duct. This is called as a cystic duct, and this cystic duct is lined by a spiral fold of mucous membrane that is called a spiral valve of Easter. It is called a spiral valve of Easter. It is called a spiral valve of Easter. Okay, so you get a fold of mucous membrane within the cystic duct, so that is called as spiral valve of Easter. That is called a spiral valve of Easter. Okay, hope so. So you have got a pouch in the neck region which is called as Hartmann's pouch. From the Hartmann pouch you get a duct. The duct is called a cystic duct, and this cystic duct contains a spiral fold of mucous membrane which is called as spiral valve of Easter. Now if you see the cystic duct joins with the common hepatic duct. So what is this duct? This duct is called as the common hepatic duct. This duct is called as the common hepatic duct. Now the the cystic duct joins with the common hepatic duct to form this main duct which is called as common bile duct. So this is called as the common bile duct. So this is called as a common bile duct, guys. Okay, fine. So what is happening here? So you got cystic duct and you got the common hepatic duct. Both of them joins to form the common bile duct, and this common bile duct fuses with the main pancreatic duct. So what is this duct? This is called as a main pancreatic duct. This is called as a main pancreatic duct. Okay, and both of them after fusion, okay, so the main pancreatic duct and the main bile duct, after they fuse, okay, they open into this area which is called as a major duodenal papillae, which is called as a major duodenal papillae. Okay, this major duodenal papillae is situated at a distance of 8 to 10 centimeter distal to the pylorus. Okay, it is situated at a distance of 8 to 10 centimeter distal to the pylorus. Okay, it is situated at a distance of 8 to 10 centimeter distal to the pylorus. Okay, so guys, if you see here, this is one important duct, okay, which is called as the fusion of the major and the major bile duct and the major pancreatic duct. Okay, so this duct finally opens into the major duodenal papillae. This opens into the major duodenal papillae. How to identify the major duodenal papillae? It is lying at a distance of 8 to 10 centimeter distal to the pylorus. It is lying at a distance of 8 to 10 centimeter distal to the pylorus. Okay, so if you see the cystic duct, okay, if you see the cystic duct and the bile duct, see, I'll just draw a simple diagram here so that you can able to. So this is the cystic duct. So you got the hepatic ducts here. So this is the common hepatic duct. So both of them fuse to form the bile duct, isn't it or not? Okay, so this is bile duct. So the lower part of the bile duct, okay, so the lower part of the bile duct is surrounded by a sphincter, The sphincter which you see here, which is surrounding the lower part of the bile duct, is called a sphincter, choledocus. It is called the sphincter choledocus. Okay, and you see the main bile duct is fusing with the pancreatic duct here, and this main pancreatic duct is surrounded by a valve, okay, or a sphincter here. This sphincter which is surrounding the main pancreatic duct is called as a sphincter pancreaticus. It is called as a sphincter pancreaticus. Okay, it is called as a sphincter pancreaticus. Now these two ducts joins to form the, okay, ampulla of Vater. So this is called as an ampulla. Of Vater, and this ampulla of Vater is again surrounded by sphincter, and this sphincter is called a sphincter of Oddi. This sphincter is called as what? Sphincter of Oddi. Okay, so this is called a sphincter of Oddi, guys. Okay, this is called a sphincter of Oddi. So please remember, so the lower part of the bile duct is surrounded by sphincter choledocus. The lower part of the pancreatic duct is surrounded by sphincter pancreaticus. The ampulla of Vater, okay, the ampulla of Vater where the bile duct and the pancreatic duct to fuse one another. This ampulla of Vater is surrounded by a sphincter called a sphincter of Oddi, and these three sphincters, okay, this one, this 2 and these 3 sphincters are together called a sphincter of, yes guys, it is called a sphincter of OD complex. It is called a sphincter of OD complex. It is called a sphincter of OD complex. Okay, this is called a sphincter of OD complex. Okay, so if you see the bile duct, okay, if you see the bile duct, okay, so if you see the bile duct runs behind the duodenum, guys. So there is a structure. So this is called as the first part of duodenum, this is the second part of the duodenum, and this is the third part of the duodenum. And you can see the bile duct running behind the duodenum, and it opens into the second part of the duodenum. Now you divide the bile duct into 3 parts. So this is called as a supraduodenal part, this is called as a supraduodenal part, okay, this is called as the retroduodenal part, this is called as a retroduodenal part, and this is called as the infraduodenal part, this is called as the infraduodenal part, this is called as the infraduodenal part. So you divide the entire bile duct into 3 parts: supraduodenal part, retroduodenal part, and the infraduodenal part. One important thing about the supraduodenal part is the supraduodenal part runs in the right free margin of, it is seen in the right free margin of the lesser omentum, it is seen in the right free margin of the lesser omentum, okay, it is seen in the right free margin of the lesser omentum. Okay, so along with that an artery is running here, that artery which you see here is called as the, okay, that artery which you see here is called as the hepatic artery, okay, this is the proper hepatic artery, and behind you get a vein, okay, which is running here, and that vein is called as a portal vein. So these 3 structures runs in the right free margin of the lesser omentum. So when you talk about the bile duct, the supraduodenal part of the bile duct is related to these 3 structures, and these 3 structures runs in the right free margin of the lesser omentum, they run in the right free margin of the lesser omentum, guys. Okay, I hope you are clear with this. Okay, so this is the about cystic duct and where it drains into. Okay, so if you take the gallbladder, okay, if you take the gallbladder, these are all the sphincters we saw. So this is the sphincter of the OD complex, we saw about the sphincter choledochus, we saw about the sphincter pancreaticus, we saw about the sphincter of OD here. So we have discussed all those things. Okay, so next thing is certain applied aspects, okay. See, when you see the area, anatomy area around the cystic region, it's very, very important, because you all know that gallbladder is more prone for gallstones, you know that. So gallstones, okay, are usually formed in the gallbladder, and most of the gallstones are bile stones, okay, and usually these bile stones are radiolucent stones. These are what? Radiolucent stones. These are called as radiolucent stones. Okay, so sometimes gas can get collected within the stones. Okay, gas can get collected inside the stones. Okay, gas can get collected inside the stone, and when you do an CT, okay, you will see this classical sign called as Mercedes-Benz sign. You see a sign called as Mercedes-Benz sign. Okay, see what I am talking is, if you see a gallstone, within the gallstone you have an air pocket or a gas pocket that will give this sign. This sign is called as Mercedes-Benz sign. So what is gallbladder is doing? Though it concentrates the bile, if a person takes lot amount of fat, more amount of bile secretes, more amount of bile concentrates, it can form a biliary sludge which can form biliary stone. When the biliary stone is formed, okay, so it can cause inflammation of the gallbladder resulting in cholecystitis. In that time we need to remove the gallbladder. When we are removing the gallbladder, the anatomy around this area must be clear. So what is the anatomy around this area? So if you see here, there is a triangle which is formed by this artery. This artery is called as cystic artery. This artery is called as cystic artery, which supplies the gallbladder. Okay, the cystic artery is a branch of right hepatic artery. So the right hepatic artery gives rise to the cystic artery, and the cystic artery supplies, okay, the cystic artery supplies the gallbladder, and this triangle which is formed by the cystic artery above, okay, it is formed by the cystic artery above, and it is formed by the right, okay, or it is formed by the common hepatic duct here, okay, the common hepatic duct on one side, common hepatic duct on one side, and the cystic duct on the other side, and the cystic duct on the other side is called as, what is this triangle, guys? This triangle is called as Callett's triangle. This triangle is called as Callett's triangle, okay. This triangle is called as Callett's triangle. And can anybody tell me what is the content of the Callett's triangle called as? What is the content of the Callett's triangle called as? You get one structure in this Callett's triangle. Very good, Vinitha. So you get a lymph node here. So the lymph node what you see here is the cystic lymph node, also called as lymph node of Lund. Very good. So this is called as the cystic lymph node, okay. So this is called as a cystic lymph node, also called as the lymph node of Lund. This is also called as the lymph node of Lund. This is called as the lymph node of Lund, okay. This is called as the lymph node of Lund. Suppose if you involve the cystic artery into a triangle taking the inferior surface of the liver as a boundary, then that triangle is called as hepatocystic triangle. So other boundaries are same. You got the common hepatic duct on one side, you got the cystic duct on the other side, but if you take the inferior surface of the liver as a boundary instead of cystic artery, then this triangle is called as hepatocystic triangle. And in this hepatocystic triangle, cystic artery becomes a content and lymph node of Lund becomes a content. Lymph node of Lund becomes a content, and this lymph node of Lund is the sentinel lymph node for the gallbladder. This lymph node of Lund is the sentinel lymph node of the gallbladder. So what is this? So this cystic node of Lund is the sentinel node of the gallbladder, okay. So sometimes what happens is, okay, the right hepatic artery may form a tortuous loop and gives rise to an cystic artery which supplies the gallbladder. So in that case, in the Callett's triangle, you see the right hepatic artery, instead of the cystic artery. So when you see this tortuous right hepatic artery in the Callett's triangle, then that anomaly is called as Moynihan hump or caterpillar's hump. That is called as Moynihan hump or caterpillar's hump, okay. That is called as Moynihan hump or caterpillar's hump. See, all these variations you should know, because when we operate in this area, they try to ligate the cystic artery, they try to ligate the cystic duct. So when they try to ligate these vessels, the aberrant vessels or the anomaly vessels, if you don't know the anatomy, then there is an high probability to injure this. So this triangle, Callett's triangle, is very important in this area, okay. Now what happens is, sometimes the gallstones can go to the Hartmann pouch and they can stay and occlude the neck of the gallbladder. So this syndrome where the gallstone occluding the neck of the gallbladder is called as Meryz's syndrome. Is called as what? Is called as Meryz's syndrome. This is called as Meryz's syndrome, okay. This is called as Meryz's syndrome, okay. So I hope you understood what is called as in gallbladder, various parts of the gallbladder, and what is the anomalies that can happen in the gallbladder. So to end this liver and the gallbladder, so I'll just draw a simple diagram, okay. See, there is a gut called as foregut, okay. So let us consider this is foregut. So this is foregut, okay. So and the foregut continues as the midgut, okay. So the foregut continues as the midgut. Let us consider this is the midgut, okay. So this is midgut, okay, close to the junction of the foregut and the midgut. So at the end of the foregut, okay, so from the foregut primitively an outpoaching starts, okay. So this outpoaching which begins in the foregut close to the junction of the midgut is called as the hepatic bud, is called as an hepatic bud, okay. This hepatic bud, when it grows, okay, so this hepatic bud, when it grows, it divides into two. One is called as the cystic bud, also called as pars cystica, The other bud which grows into the liver or which forms the liver is called as the pars hepatica, okay. So from the foregut there is an outpoaching which is called as hepatic bud, which divides into the cystic bud and the hepatic bud proper, and they enter into an area, okay, at the junction of the thorax and the abdomen, what is called as a septum transversum. What is called as a septum transversum. Okay, so in the septum transversum, the further proliferation of the pars hepatica happens. Okay, further proliferation of the pars hepatica happens. So the hepatocytes, are the structures which are derived from the pars hepatica. The connective tissues, okay, the connective tissues of the liver, okay, okay, and the stellate cells of the liver, okay, and the sinusoids of the liver, okay. The sinusoids of the liver are derived from the septum transversum, okay, so the liver is formed not only from the outgrowth from the hepatic bud, it is also formed by the septum transversum. Septum transversum is one important structure which gives rise to the diaphragm also. So below the diaphragm, you know, the liver is present. So part of the liver, the connective tissue part, is derived from the septum transversum. Okay, so this is about the embryology of the liver. Okay, so liver, since it is arising from the foregut, okay, so the blood supply of the foregut is given to the liver. So that is the branch from the cystic artery, the branch from the celiac trunk, which is called as the hepatic artery, which supplies the liver. Okay, so that arterial part, the celiac trunk, we will discuss tomorrow. So as of now, the liver and the gallbladder are produced from the outpouching from the foregut. That is the take home message. So the artery of the foregut is the celiac artery. So the branches from the celiac artery will be supplying the liver and the gallbladder, which we have seen already, okay. So this is about the liver and the gallbladder, guys. So I think we will stop with this. Okay, so we'll stop with this. We have discussed few things in the liver and the bile region. Okay, so we'll resume tomorrow. When we resume tomorrow, we'll see the rest of the abdomen, and we'll also start head and neck tomorrow. Okay, so thank you, guys. Thanks for your patience listening. So we'll resume tomorrow morning. Okay, thank you.